Uh, Greetings of the day. Welcome to this platform of Cynodent, who has served various roles in collaborating different educations in the dentistry. Myself, Dr. Monica, from the Department of Oral Medicine and Radiology. I'm also a fellow in Pavitra Academy, USA, with the certifications done in oral implantology, oral cancer screening, and the forensic odontology. Today, I'm on this platform dealing with the topic that is the vesiculobullous lesions. Before proceeding with this topic, we need to know what is vesicle bullae lesion, what is primary lesions, what are secondary lesions, the basic terminologies. Basically, the understanding of the basic terminologies is very important to cover this topic. It is, as per as the academic concern, it is important for the viva as well as for the theory, long questions. So I'll be dealing with this topic for another half an hour or 1 hour. The basic terminologies, that is, first is a lesion, which is basically a localized area of the disease or injury in a body or the tissue of the organ of the body. Any changes in the normal mucosal or the skin part can be the part of a lesion. And these lesions can be primary or the secondary. The primary ones are the basic reaction patterns with having the definite morphology. That are the examples like macule, papule, plaque, patch, vesicle, bulla, pustule, nodule, or the purpura. And if there is any disturbance in the primary lesions, this can lead to the formation of the secondary lesion, like the erosion, ulcer, fissure, second crust, sinus, or the scar formation. So the first example that we have is the solid lesions. These solid lesions, for example, the podices or the aphthous, initially, these are the primary lesions. First is the papule, sorry, papule, solid lesions raised above the skin surface that are smaller than 1 centimeter in diameter. And if the lesions are flat or circumscribed, which can be differentiated from the adjacent surface of the skin, is the macule. Next is a vesicle. These are elevated blisters containing clear fluid less than 1 centimeter in diameter, as we see in the cases of the herpes or the herpes simplex. Another example is of the bullae. Bullae are basically the same blisters but more than 1 centimeter in diameter. For example, we see in the cases of the bulla, these bulla are seen in the cases of the pemphigus or the pemphigoid. Next, we have the cyst, which is basically a pathological cavity, containing fluid, semi-fluid, or the gaseous content, which is created by the accumulation of the pus. And it is frequently, but not always, lined by the epithelium. As we see in the cases, most commonly, that is the dentigerous cyst associated in the impacted tooth. The next type of lesion is the nodule, which is basically the deep-seated in the dermis and can be easily moved. For example, we have the lipomas as nodular lesions. Then the purpura, these are basically the changes in the color of the skin because of the disturbances in the vessels or its branches. First is the purpura, which is flat lesion. The petechiae are the pinpoint, and the ecchymosis are more diffuse, larger purpuritic lesions, and the pustule, which are raised, containing purulent or the pus-like material in the lesion. Next, secondary lesion example is the ulcer, which is basically a well-circumscribed, often depressed lesion. This is the depressed lesion covered by the fibrin cloth and causing a yellow-white appearance on the overlying surface. Then we have the erosions. Erosions are basically the red lesions, often caused by the rupture of the vesicle or the bulla. If the primary lesion gets disturbed, this can lead to either the ulcer formation or the erosions on the skin surface. Like we have the erosions, the overlying surface gets disturbed, and if it is deep, then it can cause the acute ulcer. More than the 3 weeks can cause this chronic ulcers. So Based on these things, we have different classifications of the vesiculobullous lesions on the clinical presentation and the etiological factors. Clinical, whether it is pustule or plaque or petechiae or ulcer erosion, and on the etiological factors like whether it is virus associated immunological disturbance is there. Based on these etiology, we have different classifications. These are the important from the theory point of view also. That is purely ulcerative condition without any vesicle or bullae formation. If the lesion occurs without these bullae formation, then it is a case of purely ulcerative, where we have the immunological diseases like aphthous, ulcers, drug reactions, contact, allergies, traumatic lesions, where we have the traumatic ulcer. Then the bacterial infections like the syphilis, tuberculosis, tuberculous ulcers are there, syphilitic ulcers are there, actinomycosis, deep fungal infections. Like previous years, we have that mucormycosis, histoplasmosis, then blood disorders, where we have the cyclic neutropenia. If there are disturbances in the blood components, in those cases also we can have the ulcers. Then neoplasms like the squamous cell carcinoma, carcinoma of the minor salivary gland, and ulcerative conditions formed with after the formation of the vesicle or the bullae, where we have diseases like pemphigus vulgaris, pemphigus mucous membrane pemphigoid, bullous pemphigoid, erythema multiforme, and the viral diseases like herpes simplex virus, chickenpox, herpes zoster, hand, foot, mouth disease, herpangina, where and the hereditary ones are the epidermolysis bullosa. So these are the another kind of classification where we have the acute single ulcers, recurrent ulcers, chronic ulcers. In acute ulcers, we have the herpes simplex virus, coccidiovirus infection, varicella zoster infection, erythema multiforme infections, contact allergic stomatitis, HSV infection, acute necrotizing ulcerative gingivitis, and the recurring ones are the where when there are repetitive formation of more in a year, formation of these ulcers one more than once in a year. Then the examples can be the recurrent aphthous ulcer, commonly seen, then the Beckett's syndrome, where we have the triad of oral and genital and the eye lesions, and recurrent herpes simplex virus infection. Then chronic ones are the pemphigus, pemphigoid, HSV infection in immunocompromised patients. In the single ulcers, we have where there are major single ulcers in the patient, where we have the histoplasmosis, blastomycosis, and the mucormycosis. This mucormycosis were very commonly seen in the patients who were having the COVID or the coronavirus infections. Then the vesiculobullous lesions, like the herpes virus, lichen planus, lichenoid reaction, erythema multiforme. This is another kind of classification. So the ulcerations we see in the patients are of different varieties. We need to know the differences in the margins, edge, and the floor of the ulcer. Based on these clinical presentations of the ulcer, we can have a definite diagnosis what kind of ulcer it is. Like the rodent ulcers are there, deep-seated ulcers are there, as we see in the endophytic growths of the carcinomas. So basically, we need to know what is margin, what kind of a margin, edge, or the floor or the base of the ulcer is. Whether it is hard, rubbery, or we need to evaluate all those parts of an ulcer to go for the definitive diagnosis. And the margin is that area where there's a junction between the normal epithelium and the the ulcer. Edge is that part of the ulcer where there's a junction between the margin and the floor of the ulcer, and the floor is that exposed area that we can appreciate with the naked eyes. That is appreciable on the surface is the floor and the base on which the ulcer rests. Like we have the undermined ulcers in cases of patients with the tuberculous ulcers. In syphilis, we have punched out type of an ulcer. The sloping, healing, and the type is seen in the traumatic ulcers. Raised, pearly white, or the beaded are seen in the rodent ulcers, and the rolled out everted is seen in the patients with the carcinoma or the malignancy. So first type of lesion, that is the recurrent aphthous stomatitis. Most commonly it is associated with the stress, most commonly seen in the patients day to day. And this is mainly seen in the patients with the stress, having stress, anxiety before the exams. Then, if there are disturbances in the hormones, then vegetarian patients, like where they have the folic acid deficiency, vitamin C deficiency, vitamin B12 deficiency, and in some allergic patients also, this type of recurrent aphthous stomatitis can be appreciated, as you can appreciate in the image also shared in the slide. Then another is the cause that can be associated with this is the trauma. That is the systemic factors, stress, HIV infection, psychological imbalance, basically the stress, any nutritional deficiencies associated with the vitamins like B6, B12, B1, and iron and folic deficiency. Some bacterial or the viral infections can sometimes precipitate this type of ulcer. Allergic, like food sensitivity, drug allergies, can be the cause for this ulcer. This has various kinds of types, that is the minor and the major aphthous. Minor are usually seen less than 1 centimeter in diameter, located on the free or the mobile oral mucosa, appears as a well delineated white lesion with an erythematous hollow. That basically means it is surrounded by the erythematous borders, and the patient can have the tingling or the burning sensation. This kind of ulcer is usually resolved within 1 week, that is 7 to 10 days. And the characteristic part of this type of ulcer, it heals without scar formation. The another type is the major aphthous that has the tendency to last more than 6 weeks, and it heals with the scar formation. The basic difference between the two, which can be the viva or the MCQ type of question for this. Then the herpetic form of ulcer, another form of this recurrent aphthous ulcer, stomatitis, that is, there are formation of multiple ulcers, 1 to 3 mm, that is in the crops formation. This lasts for 1 to 2 weeks. Associated, this is called herpetic form because this resemble with those that are seen in the HSV patients. Differential for this can be intraoral recurrent herpes simplex, which occurs in the keratinized mucosa, pangina, which is mostly seen in the patients in the posterior palatal region. Hand, foot, mouth disease, HSV in immunocompromised patient, that can be the differential diagnosis for this. So we know the etiology. If we know the etiology, we can go for the investigations like the serum, estimation of the B12, and other nutritional deficiencies, CBC count, and the pathology test to rule out for the Beckett syndrome, where we inject some needle prick is given and we wait for 42 hours to see any reactions on the skin surface. Then the treatment for this can be the topical tetracycline solution for 5 to 7 days, topical steroids to avoid those erythematous lesions, inflammation, where we have the triamcinolone, betamethasone, and fluocinolone. This can be given in these patients. Then the kind of disease associated with this aphthous is the Beckett's disease, where there is a triad of the oral, eye, and the genital lesions. Diagnosis. The diagnosis for this is it should occur more than 3 times per year, and the lesion should involve the ocular, genital, and the cutaneous regions. Again, the line of treatment will be the systemic steroids, where we have the differential like the edema multiforme, Reiter syndrome, Conn's disease as a differential diagnosis, and the prognosis is manageable. Treatment, again, removing the causative factor, maintaining the good oral hygiene, systemic antiseptics for 7 to 10 days, analgesics if there is a kind of symptoms for the pain. Then the topical steroids may be used for a short period of time. The important point to be looked in this kind of a disease is the syndromes associated with the aphthous. This is usually asked in the viva. What are the syndromes associated with this aphthous stomatitis? That is the Reiter's syndrome, Magic syndrome, Sweet syndrome, and the PAFA syndrome, where they can be expanded as in Magic syndrome, there's a mouth genital ulcers with inflamed cartilage. Sweet syndrome, Recurrent oral ulcers, pyrexia, thrombophlebitis, and the cutaneous lesions will be there. Periodic fever, aphthous ulcers, pharyngitis. In the PAFA syndrome, then we have the traumatic ulcers where we can have the mechanical, chemical, thermal, or facetious or the radiation injuries in the patient. Mostly they are single, painful, smooth, red, whitish yellow surface, heals without scarring. Tongue, lip, and the buccal mucosa are the most common site. Mechanical, like the lip, tongue, cheek biting, hard food because of the trauma from the hard food, pin pricks, or the nails, faulty restoration, or the processes can cause these traumatic ulcers. Can be appreciated on the screen as on the lateral surface of the tongue. Then we can have the chemical injuries or the chemical burns, as in case of the patients have taking the aspirin burn, or the toothache drops. Toothache drops, sometimes they go for those pain relieving toothache drops, like eugenol. The patient can have these ulcers because of the chemical injury. Then the thermal, if sometimes accidentally the wires are kept in the mouth, then it can lead to the thermal burns or the electric burns. Based on the history and the etiological factors, the clinical features, basically, we can go for the diagnosis. The differential can be the aphthous ulcers, squamous carcinoma, and the canker or the primary syphilis. If it does not heal within the 10 to 12 days, we need to go for the biopsy to rule out for any changes of malignancy. Then the second kind of disease that we have is the category, in the vesiculobullous are the immunological diseases, like where there are the immunological disturbances in the patient. First, we have the pemphigus. The kind of different kinds of pemphigus can be pemphigus vulgaris, fallacious, paraneoplastic pemphigus, drug-induced pemphigus, and the immunoglobulin A pemphigus. What basically happens in the pemphigus is the antibodies are against our own against the antigen. सेल्फ एंटीजेंस जो होते हैं वो हमारे अगेंस्ट काम करने लग जाते हैं, वेयर वी हैव द एंटीबॉडी causes destruction of the antigen. This destruction causes the lysis or the uh, break in the cell to cell, that causes cell to cell separation, and this separation leads to the inflammation. Whenever there's a defense of the body is always to go for under the inflammation process. This inflammation causes the filling of these spaces by the edematous fluid, and there is a formation of the intraepithelial vesicle or the bulla. This is basically the pathogenesis, how these vesicles or the bulla formation occurs in the patients with the pemphigus. Pemphigus vulgaris, the most common type of the pemphigus. 80% of the patients present with the pemphigus vulgaris present with the oral lesions. Then they can develop the cutaneous lesions. The common sites are the oral mucosa, skin, nose, pharynx, larynx, esophagus, and the genitals. Mostly seen in the 5th and the 6th decade of the life. Females are more prone, that is, male to female ratio is 1:2. And the classic presentation of the pemphigus vulgaris is the thin-walled bullae arising on the otherwise normal skin or the mucosa. There are bullae formations on the skin surface, and these bulla rapidly breaks because these are very thin-walled, so they easily break and forms the denuded surfaces like the erosive surfaces on the skin or the mucosa. And the classic presentation or the sign for to present this disease is the Nikolsky's sign, which suggests that on applying the pressure to the apparently normal skin in the surrounding area of the vesicle, where there is a vesicle formation, it results in the removal of the upper layer or the epidermis and leads to the formation of the new lesion. The kind of the Nikolsky's sign that you can appreciate in the pemphigus patient are the wet Nikolsky's sign and the dry one. Where in the wet one, when you apply that pressure, you can appreciate the moist or the glistening surface, while in the dry one, there will be the dry or the healing type of lesion on applying the pressure. As you can appreciate in the video, can you appreciate in the video, the person is applying pressure on the side of the surface of the vesicle, and there's a new vesicle formation on applying the pressure. And the exudative surface can be appreciated in the active type of a lesion. As you can see the glistening surface, moist surface when this vesicle ruptures. Then another sign that you can appreciate is the Asbo-Hansen sign or the bulla spread sign. As the name suggests that a bulla, when there is this was associated with the vesicle, and if there are bulla present, you apply the pressure on the top of the bulla. This will spread. This will extend on the side of the applied pressure refers to the extension of the blister. This blister will extend to the adjacent unblistered skin surface when pressure is applied on the top of the bulla. The rare manifestations that you can appreciate in the patients with the pemphigus, there will be the involvement of the fingers or the nails as chronic or acute paronychia, subungual hematomas can be appreciated, and nail dystrophies or the deformities on the nail surfaces can be appreciated. These are the rare manifestations, and the oral manifestations can be seen in the buccal mucosa, where there will be the erosive lesions, erythematous, floor of the mouth, palate, denuded. You can appreciate the denuded skin surfaces and the labial mucosa. And gingiva is also associated, that is the free or the marginal gingiva, as desquamative gingivitis. In the oral lesions, bulla, which rapidly breaks and forms the irregular painful ulcers, a thin layer of epithelium peels away in an irregular pattern, leaving a denuded surface, as discussed earlier also. Edges of the lesions continue to extend peripherally. So the gingival lesions will present as marginal, or the attached gingiva will get disturbed with this type of disease, leading to the desquamative or the erosive gingivitis. So the differentials for this can be the Beckett's disease, erythema multiforme, erosive lichen planus, candidiasis, herpetic gingivostomatitis, bullous pemphigus, pemphigus foliaceus, folic acid and the vitamin D, B12 deficiencies. To rule out these differentials, we will discuss one by one. That is the recurrent aphthostomatitis, where we have the ulcers in the oral mucosa with yellowish base surrounded by an erythematous halo, and it has the acute course. This can be differentiated from the pemphigus. Beckett's disease, where there should be the involvement of the lesions more than 3 times in an year with the triad of oral, genital, and oral ocular ulcers. Then we have the erythema multiforme. These are the target lesions, and there is a characteristic feature of the crusting involved the lips. Bleedings are there in the oral mucosa. Then the erosive lichen planus, where the vicum striae are present. Oral candidiasis, whitish patches or the plaques will be there. Herpetic gingivostomatitis. The prodromic symptoms, as herpes is a viral infection, it should always proceed with the viral symptoms like fever should be there. Then the bullous pemphigoid vesicles or the tension blisters with clear content that develop on normal or erythematous skin. Intense pruritus should be there. Then the pemphigus foliaceus, where we don't have the oral involvement. Then the epidermolysis bullosa and the folic acid deficiency are another differentials. The line of treatment will be, for the mild cases, we'll start with the topical one, topical corticosteroids. And for the moderate, we can go for the prednisolone, 40 to 60 milligram daily. This basically depends on the weight of the patient, or we can add the topical steroids. For the severe cases, we need to go for the therapies like the pulse therapy and the systemic steroids. So yeah, in the severe cases, we have the pulse therapy, that is the DCP therapy, dexamethasone cyclophosphamide pulse therapy, where we have the 4 phases. In the phase 1, DCP therapy is given In presence of signs and symptoms, when there is severe signs and symptoms in the patient is given the dose of 100 milligram of the dexamethasone, which is dissolved in 500 milliliter of the 5% dextrose, slowly intravenous infusion over 2 hours on 3 consecutive days. Along with, we add 500 milligram of cyclophosphamide in the infusion on the day 2. In between, the patients receive 50 milligram of cyclophosphamide. Along with the infusion, we add 50 milligram of the oral cyclophosphamide. In the phase 2, when there are remission of the symptoms, but monthly DCP therapy and daily oral cyclophosphamide is continued for another 9 months. In phase 3, oral cyclophosphamide 50 milligram is given to the patient for another 9 months, and phase 4, all treatments are withdrawn and the patients are followed up for the relapse. This basically was done by Parisha way back in 2008 to treat this to patients. Then another kind is the pemphigus vegetans. These are basically as linear patterns of lace-like patterns of ulcers are seen in the patients. In oral lesion and cobblestone appearance can be appreciated in the patient. This has two types, that is the Newman type and the Halopian type. The early lesion present as Newman type, as same as the pemphigus vulgaris. Then the diagnosis is the histopath based on the new technologies. Histopath is the gold standard for these type of lesions. Then bullous pemphigoid, it is basically a type 2 type of hypersensitivity reaction, that is the cell mediated. Autoantibodies targeted hemidesmosomes. Hemidesmosomes gets disturbed because of the antibodies, autoantibodies, and there's a separation of the hemidesmosomes leading to the subepithelial blister formation. The predisposing factors can be the exposure of the UV radiations, drugs, NSAIDs, captopril, penicillamine, or the antibiotics. So the differentiating features between the pemphigus vulgaris and the bullous pemphigoid is vulgaris is usually seen in the young patients, while the bullous pemphigoid in the elder patients. Oral lesions are not seen in the bullous pemphigoid, while the oral lesions can be appreciated in the pemphigus vulgaris. And antibodies again work against the desmoglein 3 in patients with the pemphigus vulgaris, while in bullous pemphigoid, antibodies work against the hemidesmosomes. There is a superficial blister formation in the pemphigus vulgaris, while deep blisters that is the subepithelial blisters, are seen in the patients with the bullous pemphigoid. The Nikolsky's sign, as I discussed previously, is positive in the pemphigus vulgaris, while it is absent or negative in the patients with the bullous pemphigoid. When you go for the immunofluorescence examination, it shows net-like appearance of IgG in pemphigus vulgaris, while linear pattern is seen in the bullous pemphigoid. Most patients die without the treatment. Prognosis is the partially comparatively well manageable. Tombstone appearance of the basal layer, eosinophil filtration seen on histopath examination. Then next category is the erythema multiforme. Erythema multiforme, it has a typical feature of incrustations, blood incrustations on the mucosal or the lip surfaces. It is an acute self-limiting inflammatory mucocutaneous disease of the skin and the oral mucous membrane that causes variety of skin lesions. Hence the name multiforme is given to this kind of variety. The classification, that is the mild and the severe. Mild is self-limiting rash, erythema multiforme minor, and the second category is the major type, that is severe, life-threatening, or the erythema multiforme major. This can sometimes can be called as Stevens-Johnson syndrome when it is severely affected to the patient. Then the etiology, infection with the herpes simplex, Mycoplasma pneumoniae. drug consumptions like the sulfonamides. So we need to go for the history of the patient to rule out the disease, that is erythema multiforme. If the whether the patient had underwent for some medicational treatments like from the sulfonamides, antibiotics, analgesics or barbiturates, or the patient had underwent for any radiation therapy. The etiology is important to go for the definite diagnosis. Then the clinical presentation, the typical clinical presentation in the patients with the erythema multiforme is the target lesions or the iris skin lesions can be appreciated in the extremities. In the oral mucosa, the lesions will appear as shallow ulcers, erosions with irregular margins. Bleeding or the blood incrustations can be appreciated in the patients. It usually heals in 2 to 4 weeks. Intraoral erythema multiforme lesions, lips are most commonly involved and affected as eroded, crusted, hemorrhagic lesions. Erythematous or the vesiculobullous eruptions and the erosion, circumoral crusting can be circumoral crusting. That is the typical feature seen in the patients with the erythema multiforme. A recurrence is common. And the diagnosis, the appearance, as I said, encrustations or the bleeding can be seen in the circumolar part. Multiple sites involvement in half of the cases can be appreciated. Biopsy will rule out, but not always as diagnostic. So the differential for this kind of disease is the acute herpetic gingivostomatitis. Erythema multiforme affects the gingiva, pemphigus vulgaris, major aphthous ulcers, then the erosive lichen planus and the mucous membrane pemphigoid, but there we can have the gingival stomatitis. Then the treatment and the prognosis. In the mild cases, we can go for the systemic or the supportive treatment, educate hydration, liquid diet, analgesics, and that steroids as topical only. Then we have the severe form also, where we can go for the parenteral fluid replacement therapy, antipyretics, because the patients can have the fever, viral infections associated. We need to go for the antipyretics or the antivirals. Prognosis is generally good. Recurrence is more common in the erythema multiforme. Then the another category is the Stevens-Johnson syndrome, which is a complex mucocutaneous disease, affects the two or more mucosal sites. Most common triggers are the recurrent herpes simplex infection, infection with the mycoplasma, or sometimes associated with the medications. Sometimes it is also referred to as erythema multiforme major. The clinical presentation, in the general presentation, the eyes are involved, genitals and the cutaneous, that is the skin surfaces. Iris or the target lesions are characteristic on the skin, that is the target lesions can be appreciated with the denuded surfaces on the skin surface. Then the oral lesions, that is a labial, vermilion and the anterior part of the oral cavity. Early phase is macular. Erosions can be there. Lip ulcers will be there, and the foul smelling ulcers will also be appreciated in the patients. Drooling of the saliva can be appreciated, as you can appreciate in the picture also, the incrustations, the denuded surfaces of the skin and the mucosa. Gingiva is affected, the buccal mucosa is eroded. Then we have the viral infections in the same vesiculobullous lesions. That is the herpes simplex virus infection, which is basically transmitted by the contact with the body fluids. Incubation time is 7 days, followed by the resolution of virus infection. After 7 days, it gets healed. Types are the HSV1 and the HSV2. HSV1 causes oral and pharyngeal infections, and the genitals or the lower body infections are caused by the HSV2. It is herpetic gingivostomatitis. First category, HSV1 is a causative organism for this herpes gingivostomatitis. Physical contact is mode of transmission. 95% of the oral lesions is because of the HSV1. The clinical, subclinical infection can be there. Incubation period is 2 weeks. Vesicles, ulcers, crusting in this is the pattern of the formation of these herpetic gingivostomatitis ulcers. The general features or the prodromal symptoms in the patients, as it is a viral infection, so the patient can have the fever, headache, lymphadenopathy, and the anorexia. The clinical presentation, both the keratinized and the non-keratinized mucosa affected mucocutaneous junction of the lips, hard palate, and the attached gingiva. The patient can have the tingling, itching, or the burning sensations on having the food, or as he takes some tea or like hot food. Then there are the pin-sized vesicles or ulcers on the affected side. The clinical presentation, ulcers of 1 to 5 mm size, yellow fibrin base with scallop borders, and a halo, erythematous halo is appreciated in the patient. Fiery red gingiva with edema, intense erythema, painful, painful or difficulty in the swallowing can be there because of these ulcers. The diagnosis, obtain fluid from the ruptured vesicle. It is most likely to contain the virus. We can go for the virus culture to rule out whether it is the virus infection. Then the other tests we can go for is the smear collection, where we have the multinucleated giant cells, PCR examination. Serology may we can go for the ELISA to rule out for the antibodies to HSV, Western blot test. The differentials will be the herpangina, where we have the multiple ulcers on the posterior part of the palate, pillars, and the pharyngitis occurs in the summer and summer and children. Then another differential is the hand, foot, mouth disease, where we have the fever, malaise, multiple pinpoint ulcers or the vesicles at the hard palate, gingiva, but with the involvement of the hand and foot. The varicella zoster or the chickenpox infection, urinatorial infections will be, or the ulcers or the vesicles will be seen in the patients along the coarse nerve of the trigeminal nerve. Then the herpes zoster, there's a history of the recurrence, and erythema multiforme, another differential, where there will be the blood or the target lesions on the skin or the mucosal surface. So the line of treatment for the herpetic gingivostomatitis is again the symptomatic and the supportive. Start with the systemic and the supportive treatment, that is the antipyretics for the fever to control the fever, analgesics and the hydration. Then the antivirals, acyclovir comes with the name Zorivax, topical 5% cream, or the Acivate cream. There are different antivirals also available in the market. Then we have the anesthetic drugs as topical anesthetic. Then the recurrent herpetic stomatitis, where we have the reactivation of the herpes simplex virus, and the triggers can be the fever, UV radiation, trauma, or any stress. The clinical presentation, again, there are ulcers, so the patient will have the burning or the pain at the site of the recurrence, multiple grouped or the fragile vesicles that ulcerate to collapse, most common on the vermilion border of the lips on the adjacent skin. The immunocompromised patients or any oral site is more commonly seen in these type of category. Glossitis can be there intraoral on the hard palate or the attached gingiva. Recurrent herpes labialis, another category where we have the vermilion border of the lips are involved. Unilateral and recur 2 to 3 times a year whenever there is a trigger, like the fever can be there, the viral infection can be there. These get trigger and the formation of the erythematous area as papule vesicle ulcer crust that heals usually in 2 weeks. Again, the diagnosis based on the history and the examination, or we can go for the PCR reaction test. The differential aphthous ulcer that usually are non-unilateral. This is unilateral, and chickenpox, lip cancer, and the primary oral canker of the syphilis. Another category is the herpetic whitlow, which is mostly seen in the patients or the medical and the dental personnel who treat the patients had as infection had already infected with the herpes virus infection, also known as herpetic paronychia, because it involves the fingertips of the patient of the person, and can sometimes cause permanent scarring on healing. The treatment is analgesics or the antipyretics. Topical antivirals are given in the patient and oral antiviral. Then another category is the herpes varicella zoster, results from the involvement of the second or the third branch. Primary infection remains latent in the neurons. First, the patient is already infected with the varicella. Then, if there is any trigger of the latent infection because of any stress or any kind of trauma to the patient, this triggers and leads to the varicella zoster infection. The involved area can be the V1, that is the trigeminal neural nerve 1, part 2, that is V2 involvement, or the V3, that is ophthalmic, maxillary, or the mandibular branch. Whichever the branch is involved, the lesions will appear on that side of region. For example, ophthalmic branch is involved, we can have the upper eyelid infections, forehead, and the scalp. If the V2 is involved, we can have the mid-face infection, upper lip, hard palate, and the buccal gingiva. In V3, mandibular branch, we can appreciate the mandibular region involved with these kind of ulcers. Etiology is the varicella zoster virus infection, primary varicella zoster virus, chickenpox, secondary infection, or the spread from the respiratory droplets and less commonly by the direct contact. This usually occurs in first and second decade of life. The fever, headache, malaise are the prodromal symptoms in the patient. Defined, shallow defined like aphthous ulcers will be seen. Then the characteristic dewdrop-like vesicles or the pustules which rupture forms ulcer and then crust on healing 2 to 3 weeks. Secondary infection, what happens in the secondary infection? Unilateral dermatomal grouped vesicle eruptions of the skin as zoster form. Vesicle may collapse prior to the ulceration and forms crustaceans. Then the oral lesions typically occur after the skin involvement, prodromal symptoms, pain, paresthesia, or the burning and the tingling sensation. If the patient will have the pain as after the herpetic lesion, then the patient can have the post-herpetic pain, which may be very severe in the secondary infection. So the course will be maculopapular rash, will lead to the vesicle. Then the pustule formation will be there. Then the next category will be the ulcerations. These ulcers, when undergo the healing, they form the crustaceans in 2 to 4 weeks. Then finally, the patient can have the scarring and the hypopigmentation on the affected region. The shingles, another category, which is triggered by the immune suppression. Whenever the immune suppression is there, for example, in the patients with the elderly patient or the immunocompromised patients, HIV patients, HIV positive patients, malignant blood discasis, and malignant tumors undergoing the radiotherapy. These are the triggers to occur the shingle. Complications of the herpes zoster, there can be the post-herpetic neuralgia, the severe pain in the patient on the affected region, paresthesia on the anterior two-third of the tongue, which persists for 2 months or year. Neuralgic pain is usually seen with sensory loss. Ramsay-Hunt syndrome is seen in these patients. Blindness, pneumonia, these are the other categories that can be seen in the patients. Diagnosis, the clinical picture is usually that all we need in the kind of patient, because there will be the pigmentation, scarring, ulcers, pain on the involved branches of the trigeminal nerve. So it is the clinical picture is much enough to rule for the diagnosis, or we can go for the definite diagnosis as direct fluorescence antibody test, which is highly sensitive. Then differential, again, the herpetic gingivitis, pemphigus vulgaris, mucous membrane pemphigoid. The line of treatment will be the supportive care, prevent or lessen the severity of the infection with the vaccination. Antivirals will be given in the patients as acyclovir 800 mg 5 times per day for 7 days, or valacyclovir 1000 mg for 7 days. Post-herpetic neuralgia, we give the gabapentin and 5% lidocaine patch to treat the pain in the patient. The syndromes, as we have the syndrome associated with the Aphthous stomatitis, same, we have the syndromes associated with the herpes zoster, that is the Ramsay-Hunt syndrome and the crocodile syndrome. Then we have the cytomegalovirus infection. These are the primary infection in the infection mononucleosis-like diseases seen in the immunocompromised patients. And this is associated with the Guillain-Barré syndrome and myopathy with the AIDS. This is mostly seen in the patients today in the Pune cases are coming. Then we have the clinical presentation as fever, lymphadenopathy, splenomegaly, meningoencephalitis, myocarditis, or the thrombocytopenia. In the oral manifestations, the gingiva and the gingival hyperplasia will be appreciable with the coccidiovirus infections. Painful ulcers will be appreciated, and this can be co-infected with the varicella zoster or the herpes simplex virus. So again, for the lab diagnosis using the shell vials, the blood cultures are examined to rule for the definite diagnosis. Differential can be the squamous cell carcinoma because there's a growth or the in the on the oral lesions, or the gingival growth is there. Then benign or the malignant salivary tumors, traumatic ulcers, and ulcerative granuloma are another differentials. Treatment: topical anesthetics for the pain, systemic analgesics. Soft diet is advised in the patients with increased hydration, and advised if it is added super added with the viral infections, other viral infections, we need to add the antivirals like ganocyclovir intravenous 10 milligram per kg body weight per day to prevent the blindness in the patient. Then the coccidiovirus infection, this is of two types, type A and B, where 24 type A is 4 type and type B is 6 types. These viruses cause hepatitis, meningitis, or the myocarditis because different systems are involved because of this type of infection. And this can be associated, group A is associated with the herpangina, hand, foot, mouth disease, and the lymphonodular pharyngitis. In the hand, foot, mouth disease, the etiological factor of the coccidiovirus which is involved is type 10 and A16, which may occur in the mild epidemic proportions, chiefly in the children. Most commonly, age groups involved are the 6 months to 5 years, and the incubation period is less than 1 week. The clinical presentation, the patient can have, the children basically have the low grade fever, and macules, papules, vesicles will be seen on the extensor surfaces of the hand and the feet. Severe cases, the CNS sometimes, along with the myocarditis and the pulmonary edema, can be appreciated in the patients with the hand, foot, mouth disease, but only in the severe cases. Oral manifestations as sore mouth, throat, red, edematous tongue, more extensive herpangina. Short course 3 to 7 days, hard palate, tongue, and the buccal mucosa are involved. So it starts with the macule formation, then vesicles will start forming on the macular surfaces. Finally, the ulcers will be appreciated on the involved region. Diagnosis: or concomitant oral and cutaneous lesions. Then the skin lesions on the hand, feet, and the buttocks will be appreciated in the children. Antibody titer increases measured between the acute and the recovery phases. Differential herpangina, which is seen in the posterior hard palatal region, hand, foot are not involved. Herpes simplex virus infections, and the acute lymphonodular pharyngitis. Then the treatment, as it is self-limiting disease, so only the symptomatic treatment is given in the children. The prognosis is excellent. Herpangina is another category of the disease in the vesiculobullous lesions, where we have the aphthous pharyngitis, vesical pharyngitis. Etiology is associated with the coccidiovirus group A, that is 7, 9, 10, 11 type, or the group B 1 to 5 type. Occasionally due to the ecovirus 9 and 17 type. It is usually seen in the summers, and the incubation period is 5 to 9 days. Children are most commonly affected. Posterior part of the oral cavity, tonsillar pillars, and the soft palate are involved. The Occurrence of the lesion is same as in the hand foot, that is the macules, papule, vesicle, and the ulcer formation. Self-limiting, less than 2 weeks, it gets healed. Diagnosis: other viral illnesses to be ruled out to separate from the other categories of the viral infections. Course and time of year, that is the mostly seen. Course, it is less than 2 weeks, may it gets healed. Time of year, that is mostly summers. In summers, this is usually seen in the patient. And the involved or the contact with the known or the infected individual is important to rule for the diagnosis of herpangina. And the differentials, again, the hand, foot, mouth disease, varicella, and the herpetic gingivitis. The viva point of view, there's a differentiating feature between the herpangina and the HSV infection. In the herpangina, it is epidemic associated, that is in summers, and in localized area, it will be seen in the children. While the HSV has no epidemic correlation, mild pain is seen in the herpangina, while extreme pain is seen in the HSV infection. Herpangina ulcers are smaller in size, HSV infections are larger in size. Treatment: soft diet is advised in the herpangina, hydration because it's a viral infection, then antibiotics to treat the fever, and chlorhexidine rinses to avoid any poor oral hygiene because the patient is already having the pain. So prognosis is excellent. Then another category is the acute necrotizing ulcerative gingivitis, which is also known as Vincent's disease or the trench mouth. This was seen in the patients or the persons who were living in the trench areas. Hence, the name trench mouth is given to this kind of a disease. Etiology is the fusiform bacillus or the spirochetes or the bacteroides intermedius. Factors responsible are the local factors and the systemic, where in the local factors, as the persons who are living in the trench area, so having the poor oral hygiene, pre-existing marginal gingivitis, faulty dental restorations can be the local factors. Periodontal pockets can be the local factor, traumatized gingiva, smoking, and the emotional stress. While in the systemic, we have the nutritional deficiency, debilitating diseases like HIV, anemia, leukemia, and the malnutrition. The clinical presentation: age 16 to 30 years, where when they have the low socioeconomic group, as I discussed, the trench areas or the poor maintaining oral hygiene, these can have this kind of category, that is the necrotizing gingivitis. Sudden onset, tenderness, profuse salivation, metallic taste, or spontaneous bleeding from the gums, loss of taste sensation, fetid odor is seen. Teeth, we have the extruded, sensitive to tender, woody sensations in the patient, difficulty in chewing of the food, necrotic or the punched out crater-like ulcerations on the interdental or the marginal gingiva, gingiva covered by the gray slough, and the ulcers will be seen. Then characteristic blunt or the necrotizing interdental papillae with the punched out crater-like appearance will be seen. Free cortisol in the urine. Differential will be the leukemia, herpetic, these immunosuppressive related conditions, herpetic gingivostomatitis, pemphigus vulgaris, erosive lichen planus. Treatment: again, for the local debridement, ultrasonic scaling, basically maintaining the oral hygiene with the chlorhexidine rinses, 3% hydrogen peroxide plus saline 12 times per day. Basically, the main motto is to maintain the oral hygiene in the patients to eliminate the kind of ulcers. Or then another category is a plasma cell gingivitis, which is basically a hypersensitivity reaction to the cinnamon, mint in the toothpaste or the chewing gums, usually seen in the young woman. So the characteristic features are the sore or the burning mouth. It can persist in up to 3 years. Maxillary and the mandibular sulcus and the buccal mucosa are involved. Differential: the erosive lichen planus, mucous membrane pemphigoid, pemphigus vulgaris, pregnancy-induced gingivitis, chronic candidiasis. Treatment: self-limiting, takes time to heal, and additional for the inflammatory lesions, we can add the topical steroids. with the oral base as 5%. Triamcin alone commonly comes as Kenacort cream 1%. Intralesional triamcinolone injections in patients who are concerned. So these are the lesions which are seen in the vesiculobullous category. And I have completed or covered most of the lesions as per concern from the exam point of the view. So the questions that can be asked as short note is the Steven Johnson syndrome. For the long questions, we have the classify the vesiculobullous lesions of the oral cavity with detail of etiology, clinical features, differential diagnosis, and the management of the pemphigus vulgaris. While another long question can be the herpes varicella zoster viral infections with its investigations, and it can another can be the for the recurrent aphthous ulcer with the classification of the ulcer, definition of the ulcer treatment, and the etiology. So there are some clinical presentations as I have covered most of the lesions. So there are few that you can cross check with yourself what kind of a disease based on the clinical presentation. I identify the condition, and as it has involved the unilateral side lip involved with the vermilion border. So you need to answer the syndromes associated with this aphthous ulcer, what target lesion seen in this condition, and identify what kind pulse therapy is given in which kind of a condition, and what kind of a sign is this the person is elicited in the video. The above sign is present in which condition. Again, the condition three pictures are there. First is the kind of a condition where you can apply the pressure on the top and it expands to the on the applied area. Then there are different petechiae-like lesions. And the third image is the finger with the scarring or lesion or ulcers on the surface. So, based on these clinical features, I hope you can answer these conditions. Thank you from my side. Hope you understand the ulcerative vesiculobullous lesions of the oral cavity. Thank you. Have a nice day.